Yes, sir.
Hi. Who is there?
Nikhil, sir.
Hi, Dr. Manoj.
Good morning, sir. How are you?
Nikhil,
Yes, sir.
yesterday the link sent on today's name,
Yes.
Saturday.
Okay.
So I think you need to send the Sunday link to everybody immediately.
Okay. Okay, sir. I will ask Kalpesh to resend it.
Rectify this.
Yes, sir.
And on Sunday. So those who use link sent by me, I got the link. Your photos come from Perfect Square.
Yes.
Use me.
Yes. I'll check with Kalpesh.
At least the speaker and the chief guest.
Yes. All right. Thanks, sir.
So, Dr. Manoj, how are you?
I'm good, sir. How are you doing?
I'm good. Very good. That's it.
Very good. So happy to see you, sir.
So,
What's new, sir?
I was going to ask you the same thing.
I moved into my new house.
You're moving to a new house.
Moved, sir, already.
Already moved. So this is the house.
This is the house.
Closer to the first one?
Closer to the first one, but it's kind of a township. So you get the infrastructure, right?
Yeah, all the amenities.
Yeah.
Good for
I
the
can see it. Good for children.
That's what it is. Hi, Abhi.
Good morning, sir. How are you?
Good morning. All good.
So there is no cold in Mumbai?
1 minute. I take a call and get back to you.
No cold in Ahmedabad also.
That's over.
I think everybody waits for fire.
But that's the end of it. After Uttarakhand, there is no cold. Uttarakhand is the last day.
Now it is three seasons in Ahmedabad. Hot, hotter, hottest.
From March to what?
I'm sitting on 19th floor. I'm wondering what is going to happen.
Today I'm traveling to Delhi. Delhi is cold.
At least last week I was there. It was good. At least in the morning and evening. For sure. So you're going directly from Surat or coming to Ahmedabad?
No, direct to Surat, Delhi.
Hi, Sandeep.
Hello, sir. Good morning.
How are you?
Yes, sir. Yesterday you did come to Latur, sir.
I did online. It
I was there. I attended your class yesterday.
was very difficult to come physically.
Yes, sir.
So we start in 3, 2, 1. Please go ahead.
Just a second. Good morning, ladies and gentlemen. Welcome to another interesting episode of Mumbai Hematology Club. Today's session is going to be on monoclonal gammopathy from MGUS and MGCS. All that has been possible by somebody who is live on video today, our program director and moderator, Professor Dr. M.B. Agrawal. We can't thank him enough. I think India is fortunate to have him, who has enriched us by collaborating with stalwarts, and he happens to be one himself across the globe and bringing them on virtual platform every weekend. Untiring effort. Our salute to you, sir. No wonder people call you an institution in himself, a teacher of teachers. You have been conferred with many awards. The Inspiring Hematologist of India by Economic Times is one of it. And you have recently also been awarded by Guru Dronacharya Award by Indian Leukemia Award Academy. So thank you so much for bringing it and knitting it all together to convert, to make it a perfect bouquet for all of us. May I request you to take it forward from here?
Thank you, Dr. Manoj, for your kind words. Can you see my slide and
Yes,
can
sir.
you hear me? Yeah, okay.
We can, sir. We can, sir.
So good morning to one and all. Today our guest speaker is Colonel Dr. Uday Yanamandra from Pune. He's going to speak to us on monoclonal gammopathy from monoclonal gammopathy of undetermined significance to monoclonal gammopathy of clinical significance. This webinar is brought to you by Mumbai Hematology Group. It is supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and his team from INTAS, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest of the day, Dr. Sandeep Nemani from Miraj, our guest speaker, Colonel Dr. Uday from Pune, all the discussants who are themselves eminent hematologists or hemato-oncologists or medical oncologists, and you participants for sparing your Sunday morning if you are from India and afternoons or evenings if you are from the rest of the world. Next weekend, we do not have these webinars. We have the annual conference, the 48th annual conference of Mumbai Hematology Group, together with Essence of ASH, which was held in December 24. This will be from Friday to Sunday, 24th to 26th of January 25 at the venue, which is put up over here. We have 11 international guest speakers, more than 100 national speakers, and more than 70 Mumbaikars as the speakers. We have audience of almost about 350. And if you haven't registered so far, and if you wish to, you're most welcome. If you need some help towards accommodation or anything else, please feel free to write to me even in the next 2-3 days. Okay, coming back to today's webinar, the discussants. And we have got very important personalities here. We have Dr. Amit Khurana. Today he is a discussant. Very often he is the host conducting these webinars so ably. Dr. Akanksha Garg from Ahmedabad. Dr. Ashish Dikshit from Bengaluru. Dr. Chirag Shah from Ahmedabad. Dr. Deepanjan Halda from Mumbai. Dr. Malikarjun Kalashetty from Bengaluru, Dr. Nidhi Jain from Ahmedabad, Dr. Pranta Chakrabarti from Kolkata, Dr. Satish Kumar A from Bengaluru, Dr. Upendra Sharma from Jaipur, Dr. Urmi Sheth from Pune, and Dr. Vikas Goyal from Raipur. A few words about Colonel Dr. Uday. To Indian audience, he requires no introduction. He has been a brilliant personality, hardworking, great researcher, very dear friend, and has made a big name in the field of hematology, especially his own subject of his liking, the multiple myeloma. He's MD, DMSS, DNB, MNAMS, and DM Clinical Hematology. He's Professor of Medicine and Hematology at the prestigious Armed Forces Medical College, Pune. His academic achievements are large. Just to list a few of them over here, he is a recipient of various medals and the gold medals. Colonel S.N. Prabhakar Gold Medal, Brigadier I.P. Bhalla Gold Medal, Chief of Army Staff Medal, late Shri Sudhir Singhal Gold Medal, Sam G.P. Moses Gold Medal, and Rashi Memorial Medal. He is a rank holder in various subjects, including forensic medicine, microbiology, and ophthalmology from Pune University. His research publications are massive, 175 with 90 PubMed indexed, H-index 12, RG score 37.35. At a relatively young age, this speaks volumes about his ability to carry out the research, his keen interest in doing that and getting it published, and that too in the index journals. The list of his research awards is also extremely large. In next two slides, I'll just show you a few of them. Chief of Naval Staff Award, AFMRC 2022. Awarded FICP 2021. International Young Investigator Award in High Altitude Medicine, Italy 2014. Ash Scholar, San Francisco, USA 2014. Brisbane, Australia 2016. International Development and Education Award, ESCO, Chicago, USA 2016. Dr. D.P. Basu, Young Cardiology Award, API 2018. EMERC Award, API 2019. Best NBE Young Achiever Award, ANBAI 2021. Dr. J.C. Patel Best Paper Award, MHG 2021. Best Oral Paper Award 4 times by ISHMT in Korea 21. Indian Myeloma Congress, Mumbai 19. International Cancer Congress, Delhi 17. And Hematocon, Hyderabad 14. He's examiner for MD Medicine, for DNB Medicine, and DRNB Hematology. Well, ladies and gentlemen, you have a fantastic personality in front of you, speaking to you on this subject, which is very, very close to his heart. Before I give over the platform to him, let me introduce today's special guest. And that's again my friend and colleague, Dr. Sandeep Nemani from Miraj. Grateful to him for having spared this morning and to be our chief guest this morning to inaugurate this webinar. Once again, all of you from India know him. He's consultant hematologist, hemato-oncologist, stem cell transplant physician at Usha Hematology Center, Sangli. He's also attached to Sri Siddhivinayak Gammopathy Cancer Hospital, Miraj, and today he's going to inaugurate this webinar and give some words of wisdom to the youngsters as well as to the elderly like me. Thank you so much, and over to our chief guest of the day. Yes, Sandeep, go ahead.
Thank you, sir. Can you hear me?
Very well.
So, sir, at the outset, I thank Agarwal sir for giving me opportunity to share my experience and to discuss about the future of hematology, especially with junior colleagues and students. After the difficult times due to pandemic, we are again on the horizon of new hope, and a lot of new in hematology is already at our doorstep. The success achieved with chemotherapy and stem cell transplant is now taken further with the help of precision medicine with targeted agents and CAR T cell therapy. The AI is also around the corner and will bring new future in diagnostics and therapeutics. I would also like to have special mention about recent success in gene therapy for hemophilia and gene editing in our country. And I'm proud that one of my mentors, Dr. Alok Srivastav, is leading it from the front. It is the ray of hope for patients suffering from bleeding disorders and hemoglobinopathies. To speak you something very personal, we are in a fantastic and fascinating branch of medicine. A lot of work is already done and much more is still pending to be done. I am practicing over 8 years in Tier 3 city of our country, and I'm very happy the way things have picked up at my place in Sangli and Miraj in Maharashtra. We have done more than 30 stem cell transplants, including haploidentical as well as mud transplant. In the city which has no major highway connectivity and no air connectivity, this accomplishment, according to me, is not less than a miracle. I remember when I was just passed out in 2015, I interacted with Agarwal sir about prospects and further settlement. And he told me straight to go to Sangli, my hometown, and assured me I'll be doing great in my part. And yes, sir, I'm doing great. So I appeal to all my junior colleagues. The possibilities are amazing to practice in remote parts of the country. And definitely we can serve our people in our region, especially in the remote part of the country. Finally, I would also like to say, practicing medicine is not only about intelligence, but more about having courage, and applies even more while we practice hematology. Thank you, sir, and best wishes to all for their future. Thank you, sir.
Thank you so much, Sandeep. Those were words of in gold, I would say. You have given a message which is so important, and country will benefit from this one simple statement that move to tier 2, move to tier 3, and let the people of our country who are deprived of the best possible care get that at doorstep. And that's all because of the vision of people like Sandeep Nemani here. You mentioned two very important things. AI and gene therapy. And we have with us Dr. Manoj Kumar. When you talk about AI, it is Dr. Manoj Kumar, an expert in the field. And one day, Dr. Manoj, I would like you to speak to us on AI. And about gene therapy, I must also mention that INTAS has taken great steps forwards in this particular field. And we had a speaker from INTAS just 2 months ago speaking to us on gene therapy for sickle cell disease and thalassemia. So fantastic combination, Sandeep, Dr. Manoj, and now, of course, we will be listening to Colonel. So go ahead, Uday. Now the platform is yours.
Thank you, sir. Thanks a lot, firstly, for inviting me for this webinar session. Sir, thanks for your kind words of introduction, but I think you missed one single statement. I think the whole CV could have been wrapped up by saying I started my hematology thanks to Agarwal, sir. When I was an MD student, I used to come out to Mumbai to attend his talks and his lectures, and the inspiration that he is for the young generation to take hematology or pursue hematology is something which we all owe to you, sir, in the country. You have been the backbone for many of us who have taken hematology as our career. So with that, I would share my screen. So are you able to see my screen, sir?
Yes, but can this be enlarged?
Oh, sure, sir. So 1 second. So is that okay now, sir?
Okay. Vertically, it is occupying only 1/3 of the screen.
Okay,
Just go ahead. Let's see how it is.
So 1 second, sir. I'll just try to do it again. Still it the same, sir?
It is the same. It's okay.
So,
Go ahead. We
sir,
can read and see very well.
sir. To keep the session interactive, I would request all the audience to kindly scan the code. I'll wait for a second and wait for a minute, and you can scan the code and we can have the answers as an interactive session. So that we can dwell upon your thoughts so that it would, rather than becoming a monolect, it will become a dialect. Okay, the same scan code will also be available on all the screens where the questions are there. So even if you have not done it, let's go ahead. Okay, so people have already started answering. Nice. So you have a scan code on the right upper corner, if at all, if you were not able to do that in the beginning. So the first question is, well, how do you define MGUS? So as rightly brought out, so it's monoclonal gammopathy of undetermined significance. Okay, some people say no clinical signs and symptoms. Perfect. Okay, now with that understanding, what is monoclonal gammopathy of clinical significance? MGCS, clinical significance. So what do you mean by that? Okay, some say that it's all monoclonal gammopathies, okay, which are clinically significant, okay, which have pancytopenia. We'll dwell upon the pancytopenia part then. Okay, when the symptoms are present. Fine. So basically, MGCS stands for monoclonal gammopathy of clinical significance. Okay, raised immunoglobulin with clinical signs and symptoms. Wonderful. Organ damage, we will talk about it. Non-malignant, again, we'll talk about it. So pancytopenia, organ damage, and non-malignant, I'll discuss in detail then. Results in renal and other systemic problem. Fine. So let's move ahead. So when we talk of monoclonal gammopathies, there is a spectrum. So whenever we speak of monoclonal gammopathy, there is a monoclonal protein either in the serum or in the urine. Also, this straight away means there is a monoclonal gammopathy, but also if we have clonal proliferation of plasma cells in the marrow, soft tissue, or blood, which are not fitting into the diagnosis of smoldering or multiple myeloma, that also is monoclonal gammopathy. So presence of M protein is not mandatory. So let's take there is small tissue or a lymph node or some abnormal tissue or soft tissue somewhere, somebody biopsied it and you find a 7% or a 6% clonal plasma cells. And the patient might not be having an M protein at that particular point of time, but lately the IMWG has also defined that group of disorders also as under the group of the broad spectrum of monoclonal gammopathies. So when we have monoclonal gammopathies, let's talk of the common variety, that is a secretory variety. So either IgM is secreted or non-IgM, that is IgG, IgA, or IgD or E is secreted. Or these were all heavy chain related, how we were classifying, or only a light chain is secreted, which is known as light chain MGUS, or there is a plasmacytoma, as I was saying, without a monoclonal protein, with or without a monoclonal protein being there. So plasmacytomas. So this is a new group under the group of monoclonal gammopathies. Now, when you have IgM MGUS, they generally, over a period of time, progress to smoldering Waldenström's and later would become a Waldenström's macroglobulinemia, most of them. Now, the non-IgM MGUS, light chain MGUS, they, over a period of time, these light chains or these monoclonal protein can deposited in an extracellular space and can become a light chain amyloidosis. The same can progress over a period of time, become a smoldering and over a period of time as an active myeloma. A plasmacytoma generally does not have an intermediary category. So a plasmacytoma, when progresses, we directly call it as an active myeloma. Now, if it is not progressing to smoldering or to active myeloma, these non-IgM MGUS, light chain MGUS, can also go into an intermediary category known as a monoclonal gammopathy of clinical significance, which we'll be discussing in greater detail. Also, the smoldering and active myeloma can occur from IgM MGUS as well. So we have a category of IgM smoldering and IgM active myeloma as well. So this is how we look at, as for the latest definitions, the pre-malignant conditions to a precondition to a active disease. If we look at the same thing in the form of how it grows, so if you see the bottom arrows, the arrows are shading from green to red. So we have an MGUS, which over a period of time has become smoldering and has become multiple myeloma. So the levels of monoclonal protein start rising from smoldering onwards, whereas the marrow cell percentages start rising in a rapid form from smoldering to multiple myeloma, and development of end organ damage primarily occurs when a patient has got active myeloma. Now, if we have to define MGUS in a more technical format, so the definition of MGUS, it's a low clonal burden with serum M protein less than 3 gram per deciliter, bone marrow plasma cells less than 10%, and with M protein in the urine less than 500 milligrams in 24-hour urinary protein. There should not be any end organ damage or effects in the form of CRAB or SLIM criteria. Generally, MGUS is seen more in males and is seen in a higher proportion in blacks. The median age is around 64 to 72, but we'll dwell slightly more upon the median age in the next few slides. And I'd be discussing the MGUS under the following headings of definition, natural history, diagnosis, risk stratification, and our experience from India. Now, that was broadly about MGUS. Now we have a category known as light chain MGUS, wherein an abnormal FLC ratio less than 0.26 or more than 1.65 with increased level of involved light chain is to uninvolved light chain with no immunoglobulin heavy chain on immunofixation with again absence of end organ damage in the form of CRAB criteria or amyloidosis related plasma cell disorder, clonal bone marrow plasma cells less than 10% and a urinary M protein less than 500 mg per 24 hours. Please, for the audience who are listening, particularly the students, you need to understand if there is an amyloidosis from any organ directed biopsy, they do not fit into the diagnosis of light chain MGUS. They will be labeled as amyloidosis AL type in that particular situation. Now, the natural history, if you look at the bottom two curves, the IgM MGUS progression is slightly higher than the non-IgM MGUS progression over 30 to 40 years. And the death because of other causes other than the disease per se are much more when compared to death primarily because of the disease per se. So MGUS, we can call it, rather than calling it pre-malignant, we would say this is that type of malignancy or that stage of malignancy wherein the progression is extremely low. The natural history, though I told you that the median age at diagnosis is 64 to 72 years, but the disease or the MGUS starts occurring somewhere between 25 to 30 years of age. And this is from Dr. Nikhil Munshi's papers. And he has shown it evolves over a period of time. So in the males, it starts rising rapidly after 45 to 50, whereas in the females, there's a lag of another 5 to 10 years when compared to males. So the incidence in females is slightly lower when compared to the males. If you look at the survival, the expected survival and the observed survival are more or less close, with a slight gap in the survival curves, but this gap is not statistically significant. So if monitored properly, they can have the expected survival. But in those situations where there is no monitoring taking place, few of these patients directly present to us with end organ damage and thus might have slightly lower survival. But MGUS, when picked up early, will have survival close to that of the normal individuals. If you look at this Venn diagram of genetics and the relation of MGUS, and if we can predict, this whole study again was done by Ola Landgren. They said that at the time of diagnosis of MGUS, by looking at the genetic makeup of the patient, can we predict who progresses earlier when compared to who does not? Which again, I'll show it as part of the risk stratification. But you would see that the proportion of patients with MGUS in the bottom curve, in the bottom bar diagram, that with 2 genetic abnormalities, 3 cytogenetic abnormalities, 4, 5, 6, 7, and 8 plus is more or less the same. So many of the patients might be having these genetic abnormalities upfront, rather than we saying they are developing over a period of time, mutating and developing. So many of them have it from the baseline onwards. Now, these studies are based on single cell genotypes because it's a oligoclonal situation when the patient has MGUS. So the number of clonal plasma cells might not be huge. So they have found that there can be variety of combination of these genetic abnormalities. Now, most of them are generally not diagnosed. So if you see the orange curve on the top, that is the prevalence survey, wherein it shows that it is 1.3 to 2.4, 3.8, 5.8, 7.4% at 5th, 6th, 7th, and 8th and 9th decade. Whereas the clinically detected one, there is a huge gap. So out of all cases of MGUS, only 20% are clinically detected, and rest, most of them are only picked up during prevalence surveys or research studies where we are looking at a door-to-door survey to pick them up. So many of these patients are not picked on in a bedside or in the hospital scenario. Even when they are picked up, the patient would have actually come to the hospital for some other disease or has been part of some executive health checkup or something, and wherein this has been accidentally or incidentally picked up. With the advent of mass spec, the number of cases which are being picked up have increased. In fact, you'd be surprised, the latest paper by group from Irene Gabriel this year in ASH 2024, they say at 45 years of age, 45% individuals have got a monoclonal gammopathy. These numbers were not palatable or digested by any of the myeloma experts in the ASH, but now they have labeled it as a term, the way we have CHIP, CHIP. So they have labeled a term known as MGIP. And they say that if you carefully look by mass spec and single cell genotype, you could pick up patients with monoclonal gammopathy. Around 40 to 50% of the normal population would be having some abnormality when you try to evaluate at age of 45 to 50 years. The next question is, how do we stratify? Once we have picked up a patient as having MGUS, how do we know which of these cases would progress, which of them would never progress in their lifetime? So for that, people have come up with 3 major factors. One is serum M spike less than or more than 1.5 gram per deciliter. Second, what subtype is it? E.g., is it IgG subtype or non-IgG subtype? And is the FLC ratio with a normal range or not? That is 0.26 to 1.65. And based on these 3 factors, which of them are abnormal? So you will find 3 different graphs on the top. So if all the 3 factors are abnormal, the chance of progression are much higher. Whereas if there are only 2 factors, you see the solid black line in the middle, the second one, you would see that the progression is slightly lower. So depending upon few risk factors, you can predict which of these individuals might have a higher risk of progression. And they have then converted this into a risk strategy, which we are going to discuss in the next 2 slides. Second, coming to the genotype, again, they have classified all those abnormal genetics into high-risk fish, intermediate-risk fish, and standard-risk fish. And they could see that those patients with high-risk fish have a high rates of progression, whereas intermediate, standard, and low-risk, the graphs are not very separable. They are almost close to each other. So putting all of them together, so these are the various predictive factors which have been spoken about: the M protein size, IgG versus non-IgG, the FLC ratio abnormality, polyclonal immunoglobulin suppression, circulating plasma cells, urine light chain, age of the individual, and bone marrow plasma cells. Again, out of all these groups, when the IMWG sat together, they deleted few of them. They said, though all of this does have a role in predicting progression, if we have to pick the top 3, so they have removed this, and they kept only these 3 factors. So on today's date, at bedside, if we want to monitor a case of MGUS, just look at the size of the M protein, look at the subtype, heavy chain subtype, and look at the FLC ratio. Based on these 3, you can then say, if none of these are present, you call them as uncomplicated MGUS, and a bone marrow biopsy and a skeletal survey may be deferred. You don't even need to do any further evaluation for that. But if any of these are present, or there are unexplained symptoms present in the patient, so in such cases, you need to subject these cases of MGUS to a bone marrow biopsy at baseline, along with a low-dose PET-CT or a conventional radiogram to look at, are there any skeletal involvement in these patients. Now, once we have done that, and at the baseline, after doing all those evaluations, that is skeletal survey and bone marrow biopsy, we said that, okay, this is not smoldering. This still fits into MGUS. So then the question arises, how do we follow up these patients? So we follow up these cases by all these patients are supposed to undergo the first follow-up at 6 months. At 6 months, if you look at again these 3 factors, that is the M protein and the FLC ratio and the IgG subtype. So if the M protein and the FLC ratio are stable, then you risk stratify based on the factors, and those who have low risk, that is, who have 1 or less of these 3 factors, there is no further follow-up required at all. Whereas if you have 2 or 3 of the risk factors out of the 3, in such patients, an annual MGUS follow-up needs to be done. And when we say annual MGUS follow-up, they need to undergo a CBC, calcium, renal function test by studying the creatinine and creatinine clearance, looking at M protein quantification and FLC quantification. So based on those 3 factors, we classify them into low or intermediate and high risk. Low risk, just leave them as it is. You don't need to do anything further. Now, at 6 months, if you see any sort of progression in the disease, either in the symptomatology or in the lab parameters, you need to evaluate both for lymphoid disorders and plasma cell disorders. And if the patient has any features of malignancy, they are managed accordingly. If they have none, again, they undergo an annual follow-up with the tests which are there. Now, when I say lymphoid as well as plasma cell disorders, many of the M proteins can be secreted by B cell disorders also. So they need not be dysproteinemia secondary to plasma cell disorders. A patient with lymphoma can also have a small M band. So thus, while evaluating, they also need to be ruled out for lymphoid disorders. Now, after we understood the definition, natural history, how to diagnose, how to risk stratify, and how to follow up these individuals, the biggest question arises, this is all Western data. What is Indian as far as MGUS is concerned? So our experience, we have done a first study, which was done in Kasudi village, which is in Dawn district next to Pune, wherein we have evaluated these individuals, approximately 1,000 individuals with, we asked for 9,000, we went and screened around 8,000 individuals, of which around 1,000 were above 45 years of age. And we then screened them, all of them with serum protein electrophoresis, and we found around 15 patients were positive, and which were then confirmed on SIFE as well. So this is how they were there. So based on this, we came up with a percentage of 1.75%. But then people said it's a very small population to be extrapolated to the country. We need to expand this further. So we then further expanded it, which we are going to present in the annual meeting of MHG now. And you would see, I'll just give the highlights of that particular thing. So you would see that of the whole numbers that we have done now approximately 100,000 patients, and of which we found that the prevalence is around 1.79%, which is comparable to that of the other Asian countries, but much lower when compared to US and Europe. So we have around 1.79% individuals here. So to summarize whatever we have spoken about MGUS before we go to MGCS. So MGUS is a presence of monoclonal process in the body, either in the form of monoclonal protein or monoclonal plasma cells, either medullary or extramedullary. Symptoms and signs related to organ dysfunction are rare. If they are present, you require a detailed evaluation. And if when you have any of these, then you need to treat the clone. And how do we do that? Let's go ahead. So for going ahead, I would take you through some important day-to-day questions which we encounter in our daily practice as a hematologist or as an oncologist. So we often get referrals from neurology clinic saying that there's a case of CIDP or a polyneuropathy with M protein present during evaluation. They refer the patient to you, say, is this myeloma? Do we require therapy or does he not require therapy? You get referrals from dermatology most of the times, where in some skin lesions, they did a biopsy and they find a plasmacytic infiltrate in the dermis, or there is a M protein which is present in the protein electrophoresis. Or we get a referral from blood transfusion department saying that there's a case of hemolytic anemia, and we processed on ourselves from the blood bank. We sent the samples for SPP found to have M protein. Or a rheumatology clinic saying there was a patient with thickened skin and a patient was having difficulty in opening the mouth. As a panel, nowadays scleroderma panels of most of the outsourced labs, they have SPP as part of it. So they say we did a panel, scleroderma panel, and in that M protein was positive. Or nephrology panels. Nowadays, since the time panels have started, so people have started putting, even in polyneuropathy panel by Lal Path Labs and Metropolis, you have got SPP as part of it. So there is a CKD panel which was done for all the causes of CKD, and you suddenly find that the patient has got a M protein in a patient who was already diagnosed as CKD for last 6 to 7 years. Now, what do you label? Do you call him as MGRS now, or is it just a silent bystander? So these are the common referrals which we get on a day-to-day practice. So let's go ahead and discuss how do we go about it. So these are some of the most difficult consultations, particularly if the patient has some other comorbidities. So the most important aspect which MB Agrawal sir, our teacher, keeps harping upon every time in all his lectures, a good history and examination go a long way. Now, most of the subspecialists on today's date, they have shotgun approach wherein they first, before even talking to the patient, they order a panel of tests. But please spend some time, talk to the patient, take a good history as a good clinician and put a hand on the patient. You'll get a lot to know and you could actually rule out many of the differential diagnoses. Now, when we talk of treatment in most of these MGCS cases, what I'm going to describe in next 10 slides is all anecdotal. But making a diagnosis is a first step, which is extremely important because if you have a clear diagnosis, so you can then thereafter decide about either a clone-directed therapy, IVIG, whatever you want to give, you can then thereafter decide about it. Now, most of these patients have excellent survival, but diagnosis and treatment prevents and reverses the morbidity in most of these cases. So with this few pearls of wisdom, let's go ahead and talk about, first of all, what is the difference between MGUS and MGCS. So when we say MGCS, most of the monoclonal gammopathies, which are causing important diseases. So here there are two problems which occur. One is there is a small quiescent B cell clone, which is causing the pathology and which is producing a M protein, and or it is producing a M protein. So the symptoms related to this M protein or to the clone itself by mechanisms other than tumor burden. So it's not the tumor burden which matters here. It is a sort of reactions or a paraneoplastic manifestations in oncology terms, which is leading to this unexplained symptoms in these patients who otherwise do not fit into smoldering or into overt myeloma. The mechanism of tissue injury is very different. And depending upon which organ it affects, we then classify it into different groups. So if there is a MGUS, which is associated with renal dysfunction, you have a group of disorders. With vascular leak syndromes, you have another group. With neurological involvement, you have a separate group. It affects eye and skin in other parts. So with this, let's take upon the important ones. We would not be covering everything, but we will touch upon the important aspects. So the 4 important groups are neurology, dermatology, inflammatory or capillary leak, and renal diseases. So let's go one by one. So first, coming on to the neurology. So before we go ahead, I would like to ask one question just to see that most of the people are not sleeping and are attentive to the class. So do you evaluate every case of polyneuropathy with SPP or SIFE? If a patient comes to you, or as I told you, polyneuropathy panel. So if at all you as a clinician or a physician, a patient comes to you with polyneuropathy, do you feel it's important to evaluate everybody with SPP or SIFE?
Yes.
So as sir said it, so yes, it is very important because we need to understand most of the neurological disorders do not have directed therapies. This is one of those where you have a reversible therapy. So B12, hypothyroidism, and a monoclonal gammopathy. These are few of the causes where you could treat them and reverse the causes. So it is important. Wow. For the next one, many people have already answered. Names of neurological conditions secondary to monoclonal gammopathy. So people have said polyneuropathy, distal polyneuropathy, ataxia, Alzheimer's, demyelinating disorders, POEMS, CIDP, dementia, okay? Mononeuritis multiplex, okay? Wonderful. So we agree. So the monoclonal gammopathies can lead to wide variations of neurological disorders. But if we have to put them in a sequence, and as most of you have said, neuropathy or peripheral neuropathy or polyneuropathy is important, let's talk about that then. So if we talk of monoclonal gammopathy along with peripheral nerve involvement, so these are the ones which are important. AL amyloidosis, POEMS, DAT syndrome, Canomad, cryoglobulinemia, and scleromyxedema. Now, the top 2, that is the AL amyloidosis and POEMS, are a topic in itself. AL amyloidosis, I'll not go in detail, but rest of them, we will just talk it in brief. So that's MPN. So though don't go by the abnormal name given to it or an acronym given to it, but a distal demyelinating symmetric neuropathy is quite common. Now, if somebody tells me what is the commonest cause for this, I would label the first common cause as diabetes, then considering the diabetic pandemic in our country and in this age group of elderly. Second would be B12 deficiency. But if I'm a neurologist, the way we go ahead with all symmetric peripheral neuropathies is to look whether they have got MAG, anti-MAG, or they do not have anti-MAG. So if they are not having anti-MAG, then the B12, the diabetes comes into. But if you have anti-MAG, then you should think about monoclonal gammopathy of clinical significance with peripheral nerve presentation. And these patients need to undergo a SPP to rule out a M protein being present or not. So the step 1 is to do a anti-MAG in all these patients. Now, the second disorder, I've also given the clinical phenotype here. Those who are interested can read it out, but I'll not waste time on that. So I'll go to the second one, which is Canomad. Canomad actually stands for chronic ataxic neuropathy, ophthalmoplegia, presence of an M protein in the form of IgM. So M stands for IgM. AD stands for agglutinin disease and disilolcyl antibodies. So this is a full form of it. Now, on a bedside, how do you pick it up? So if a patient has got cerebellar features in the form of ataxia, so go ahead and rule out whether this ataxia is cerebellar in nature or sensory in nature. So the best way to do it out is make him stand straight. If he is having a good balance, then ask him to close the eyes, do a rhombus. If rhombus is positive, then it is sensory ataxia. Or the patient will tell you a wash basin sign. He's trying to wash his face and he's falling in the wash basin. So then that gives you a clue that this patient has got sensory ataxia. Because Canomad, 100% of the patients have sensory ataxia. Second is ophthalmoplegia. So you find a new onset squint in the individuals. And on evaluation, you find that there are cold agglutinins or there's a difficulty in blood typing in these patients or a cross matching. In such situations, please think about getting a protein, M protein done, and this can all be connected together as part of it, because otherwise connecting ophthalmoplegia, which is in mid-brain, and sensory ataxia, which is either thalamus or along the posterior dorsal column, is not very easy if you look at the anatomy of or the way we classify the neurological disorders. So the only way to put them together is by this particular syndrome. Again, by treating these individuals by clone directed therapy, you can have 100% reversal of these individuals. Though these patients also show reversal with rituximab or IVIG type of therapy. So it's extremely important. And when we talk of diagnostic testings, so first do a NCCS, thereafter NCS, that is not NCS, NCS, that is nerve conduction studies, and do an anti-MAG, and thereafter look for sialosyl antibodies and SPP. You will be able to pick up these tests. The next we talk about is a POEM syndrome. So when we say POEMs, we have got some major and minor criteria, but out of the major criteria, the two which are marked in blue are the mandatory criteria. So the patient need to have a polyneuropathy and have some M protein or a monoclonal plasma cell dyscrasia. Mostly it is lambda light chains which are present. So when you have these two, then look for the other criteria. So out of the criteria which are marked 3 to 4 or 3 to 5, you should have at least one. And those which are marked from 6 to 11, you should have at least one to label the patient as having POEM syndrome. Now, please remember, when you say polyneuropathy, the polyneuropathy should not be because of any other causes. So if a patient is diabetic, a diabetic polyneuropathy, and endocrinopathy, you are labeling diabetes as endocrinopathy, and the patient is having a vascular leak because of diabetes, diabetic retinopathy as papilledema is not acceptable. So you need to rule out any other evident causes which could explain it. And once you rule them out, then only you can label the patient as having POEM syndrome. So these are the ones which are the commonest or the easiest things to do at the bedside. So polyneuropathy and monoclonal protein is not difficult to pick up. Do a VEGF level and look for thrombosis or polycythemia. You would more or less 70 to 80% of the cases you won't miss by looking at these 4 factors which are put as the star marks. Now, after you label a patient as having POEM syndrome, please do a bone marrow biopsy and from the iliac crest. And if you find clonal plasma cells, they need to be subjected to systemic therapy. For those who do not have a clonal population more than 10%, then look at the number of bone lesions by either doing a low dose whole body CT or a PET scan. And if they do not have more than 2 lesions, you can just give them radiation. If they have more than 2 bone lesions, they should be again subjected to systemic therapy. Now, this is how you go ahead with the chemotherapy. But there is also evidence to show that POEM syndrome can be directly taken up. Amyloidosis and POEMs are 2 such syndromes which can be directly taken up for the autologous transplantation when the plasma cell load is less than 10%. In such patients, they can directly be taken. But both POEMs as well as amyloid patients, they need to be explained. The organ dysfunction which is there might not revert by autologous transplant or by systemic therapy, particularly the neuropathy component of it. In such patients, the treatment that we are offering is to prevent further progression rather than for reverting the neurological dysfunction which has already taken place. So again, the same thing where I told you without chemotherapy, if you want to take them up, so you can take them up directly for transplant or after giving Lendex or Meldex. So POEMs is one of those disorders where still doublets are a component of therapy, because in rest all plasma cell disorders, we have shifted over to triplets. But this is one place where you can still get away by giving doublets to these patients to avoid a lot of complications. And the reason why doublets are thought about in this is because bortezomib leads to some amount of neuropathy and or proteasome inhibitors, whichever you give. So they will definitely add to some neuropathy. So that might worsen the neuropathy or the autonomic dysfunction which the patients of POEMs or amyloid have. So you can just give an IMID along with a steroid and take them up for transplant. Engraftment syndrome is a major complication in both with POEMs as well as with amyloidosis. In fact, in amyloidosis, giving GCSF for cell mobilization can lead to problem. So therefore, you should be slightly careful and please think about engraftment syndrome as a major problem for POEMs patients. So it needs to be managed timely with steroids. And if you look at the survival and others, the POEM survival is much, much, much better when compared to that of the multiple myeloma or overt myeloma which is present. Now, these are all other neuropathies which can be related to M protein. We have only spoken about the DATs, the Canomad, and the poems. But for those who are interested, we have got non-IgM and IgM related. Again, they are divided into anti-MAG and non-MAG peripheral neuropathies and other named syndromes which are here. So you have a group of neurological dysfunctions which can be secondary to M proteins or to the dysproteinemias. And this is how you evaluate. I'll not waste time on that. So coming to quickly to the last slide of the neuropathy neurological part of it. So when you have a monoclonal gammopathy of clinical significance with neurological involvement, the first line therapy in poems is clone directed. The second line therapy is clone directed in poems, and supportive care becomes the other forms of therapy. Whereas in cryoglobulinemia, we need to treat the underlying cause, which in this particular case happens to be clone directed therapy. And as a second line therapy, you can give anti-CD19 or CD20 therapy, rituximab being the better one. Now for the rest three, that is DADS, Canomad, and the sporadic late onset Nemeline myopathy, IVIG works wonderfully. In fact, we had two patients in our setup where they were labeled as Canomad, and by just giving IVIG, you could see most of the manifestations of these patients had reverted. So that works well. Now also, secondly, when neurologists, they manage most of the neuropathies or CIDPs, what they do is nowadays a plasmapheresis and IVIG is their first line of therapy for unexplained polyneuropathies. Most of those patients who are improving, which were not evaluated for dysproteinemia, might have been actually a plasma cell disorder, which would have got benefited by giving IVIG or plasmapheresis in those. So it's good to get those patients evaluated upfront rather than we blindly giving them IVIG or plasmapheresis. So with that, I would stop the neurology part. I would now take you on next to the other parts very quickly. The next one is capillary leak syndromes. So when we talk of monoclonal gammopathies, this is a very important component, and most of us would have seen one or two patients in our follow-up with these problems. So in fact, I currently am managing a case of systemic capillary leak syndrome, which is also known as Clarkson disease. So the patient came to us with complaints of orthostatic hypotension and having bilateral pedal edema, and this patient has gradually worsening hemoconcentration. This was all acute in onset. So as a general physician, I first thought this could be dengue, because nowadays dengue is going on quite common. Hemoconcentration, some pedal edema because of third space losses, and patient having orthostatic hypotension because patient was not hydrating herself well. But on evaluation, the albumin level was low and there was an AG reversal. The AG reversal led us to get a SPP done, because that's a reflex thing which happens in our setup. And we found that there was an M protein which was present. In the meantime, while we were evaluating the patient came to the emergency. She was a 52-year-old lady with shock. And we gave her IVIG and the whole symptoms got reverted. And patient got discharged within 3 days in a walking, talking state. Now, this syndrome is important to identify, because if the shock not being picked up in a right fashion or in a timely fashion can be fatal in nature. These patients can also come to you with hemifacial edemas, angioedema presenting as swelling of the lips or hoarseness of the voice. So this is one syndrome where by just thinking of this particular condition and giving IVIG can actually prevent fatalities. The second group of disorder is cryoglobulinemia. It's a condition which is characterized by symptoms like cutaneous purpura, skin ulcers, Raynaud's phenomena, acrocyanosis, libido reticularis, digital ischemias, or particularly all these symptoms worsening during winter seasons. Or it could be asymptomatic or an incidental diagnosis. Or a patient with a lymphoplasmacytic lymphoma has suddenly come to you with a rare ulcer. So this could present in a myriad manifestations. And these are all the ways that these patients can come with. So other than the cutaneous and the hyperviscosity, they can also come to us with arthralgias, with peripheral neuropathy, with lung, heart, or GI disorders. When we evaluate these patients, the most important thing is a cryocrit. But many a times, the patient's diagnosis gets missed. Patients get picked up by having an M protein, by SPP or a SIFE. We all, whoever is doing viscosity, they routinely have high viscosity. But because we don't use pre-warmed tubes for such patients, So when the samples are sent in a normal vacuum and particularly in North India, these things get missed quite frequently. So when I was doing my DM at PGI, it was a routine order for all of us from our teachers that in winters, whenever a patient comes with such findings, the collection has to be added in the lab, or there have to be pre-warmed tubes, which needs to be done. If you don't pre-warm, you might miss the diagnosis in these individuals. So how do you manage? Asymptomatic patients just observe, symptomatic patients do a clone-directed therapy. And how do we do a clone-directed therapy? So this is how we go ahead. So these patients can be given bendarituximab or some steroid-based therapy, or they also respond to rituximab or BTK inhibitors. So these are the various ways, and depending upon which part of the disease burden or the symptom burden the patient has, you can keep increasing the therapy accordingly. The next part is Schnitzler's syndrome. Now, this particular syndrome, it's a IL-1B, which plays a critical role in this particular disease. And when we look at the disorder, so we have got some criteria for labeling these patients. So these are those patients who come with chronic urticarial rash and who have got an M protein present. So they are generally referred to you from a dermatology by saying, इनको कभी-कभी बीच-बीच में बुखार आ रहा है, and हम लोगों ने X-ray कराया था, तो X-ray के अंदर the patient had got some decreased bone density. And on biopsy of these skin lesions, there was a neutrophilic infiltrate who often get labeled as having either Sweet syndrome or scleromyxedema. So these are those patients who should be evaluated for this particular disorder. And the diagnosis is based on the Strasberg criteria. And depending upon the criteria, you either label them as definite diagnosis or probable diagnosis. The treatment, I'll talk along with Tempe syndrome, which is another syndrome, which is done alongside. So Tempe syndrome, TEMPI stands for T for telangiectasia, E for elevated erythropoietin or erythrocytosis, the M for monoclonal gammopathy, P for perinephric fluid collections, and I for intrapulmonary shunting. So the patients can come with any of these disorders, and the ultrasound of the kidneys is what I have shown you here as an insert, is one which is very characteristic. So you'll have perinephric fluid collections, and these are those patients who come to you with low SpO2 because of intrapulmonary shunting, and they often have a high hemoglobin values. The last one is cold agglutinin disease. And again, for all hematologists, this need not be spoken in great detail, but it's a chronic hemolytic disorder with positive DAT and with monospecific DAT for C3D, with CA titers generally more than 64, patient presenting with fatigue, cold-induced symptoms, and with increased risk of thrombosis. And the evaluation is on the left-hand side, the way we go about evaluating these particular patients. But as you see in the right bottom, for patients who do not have an underlying disease, which can explain a cold agglutinin disorder or a CAS, in such patients, we should do protein electrophoresis and a bone marrow biopsy to look for a plasma cell clone. This is something which should be done because most of the times, the patients of cold agglutinin disease, they are not evaluated enough for the secondary causes. So please look at that. So this is how we evaluate. And the next algorithm, I'm going to show how you treat these individuals. So depending upon whether it is primary or secondary, we divide the therapy. Most of our cases would be labeled as cases of secondary CAS. But MGCS, because the monoclonal protein as well as the clone is so small, sometimes they might be falsely labeled as primary CAD. And on follow-up, after 6 months to 1 year to 2 years, you suddenly find that these patients have come up with a small propped up M protein, and then retrospectively think this would have been a case of MGCS, which was present. So this is how we go ahead with the treatment. Now, next, coming on to the dermatology part of it. So we have got various skin manifestations. So the most important of them is scleromyxedema. As you could see in the panel C below, where a patient has got a leonine facies. And in the panel 1, you find that there is a difficulty in closing the hands because you find that the patient has got a lot of skin thickening which is present. So scleromyxedema patients come with leonine facies. They come with donut sign. This is how it is. So if you see the hand there on the knuckles, you'll find those oval shaped things with a central vertical bar. So these are the ones which are known as donut signs. And you would see on the back, that these patients have got as if they are wearing a shawl or it's wrinkled back, which is known as Sharpie sign. So these are the combination of the signs which the patients can present with. And when you do a biopsy of these individuals from the skin lesions, you'll find that there's an infiltration by fibroblasts. So the monoclonal gammopathy associated scleromyxedema can be divided into complicated ones or severe and non-complicated ones. So those who are complicated, so they require high dose steroids along with plasmapheresis as an emergency. For those who are not complicated, where there is only cutaneous involvement and there's no involvement of heart, so those patients can just be managed with IVIG therapy. And depending upon the response, you could then thereafter start either anti-plasma cell therapy or continue with high dose IVIG maintenance. The second figure, if you look at these photographs, any general physician would say that these are features of hypercholesterolemia, or these are those places where the patient has got increased xanthogranulomas. So you have a condition known as necrobiotic xanthogranulomas. So just presence of xanthomas, xanthelasmas is a feature of hypercholesterolemia seen generally in patients who are obese or who are hypertensive. But when these xanthomas or xanthogranulomas start getting necrosed, then you should think of this condition known as necrobiotic xanthogranulomas. And these are commonly seen with plasma cell dyscrasias or paraproteinemia. So please do a SPP in that patient. But there's a very beautiful article written by Angela Dispenziari in 2020 about the various disorders and how they can have different manifestations affecting different organs, and whether it is a clinician who picks it early or the pathologist who picks it early. So that is available as a grid diagram. So for these patients who have got rheumatological disorders, IVIG happens to be the first line of therapy, except Schnitzler syndrome, where it is IL-1 mediated. So anti-IL-1 remains to be the first line of therapy. So this is how we manage patients of MGCS with dermatological manifestation. Now, the last component is renal or MGRS. So again, I'll just ask one question to the people before we go ahead with the discussion. So the question is, do you evaluate every case of CKD for monoclonal gammopathy? Now, this could be a patient who is known CKD or a newly diagnosed CKD based on the latest definitions of GFR less than 50. So whichever way that we say, ESRD, CKD, whatever. So we have only 2 people who have answered. But yes, I agree with this, that every patient of renal dysfunction should be given an option of getting evaluated for plasma cell dyscrasias. Again, as we discussed in neurological manifestation, these are reversible conditions. So organ can be spared if they are diagnosed in time. So the second question, there's a 60-year-old male presents with fatigue and gradually increasing pedal edema. Investigation revealed elevated creatinine and proteinuria. Further evaluation revealed IgG kappa on SPP and SIFE. Is this patient a case of MGRS or no, it is not MGRS? Okay. I would partially agree with the answer, but I'll explain why. So when we say that the monoclonal protein or a plasma cell disorder can affect the kidney, please understand the plasma cell infiltration of kidney is extremely rare. In around 1,000 biopsies done at PGI as part of autopsies, only 2 patients had direct plasma cell involvement. Most of the time, it is a protein secreted, either the heavy chain, light chain, or a combination, which is affecting either the blood vessels, the glomerulus, the Bowman's capsule, the proximal distal loop of Henle, or collecting that. Depending upon which part is involving, you've got a huge nomenclature. People have given different names to it of how these monoclonal proteins can affect different parts of the kidney. Depending upon which part it is affecting, you'll have different manifestations. So if it is the Bowman's capsule, the blood vessels, and the glomerulus, which is involved, the patients can present with proteinuria, which is in high range or nephrotic range. If it is the proximal tubule, the loop of Henle, or the distal tubule which is affected, The patients will have proteinuria, but it will be microalbuminuria, and the protein which is excreted will be extremely small. So proteinuria can be a manifestation still of MGRS or the clone. Now the next question is there an indication of kidney biopsy in every case of suspected MGRS or monoclonal gammopathy with renal dysfunction? Will you subject every case to kidney biopsy or not? If yes, what are the indications that you will think about? If you feel that in particular cases that you will do kidney biopsy, you can type out your answer. And I promise this is my last question. I will not ask you any more questions. Okay, so if you're not answering, I presume that you would subject everybody to a kidney biopsy in every case of suspected MGRS. Okay, so with that, the answer is yes. So in every patient who have got a monoclonal gammopathy with renal dysfunction, you should think of a biopsy. But if I have to put it more technically, the way I would go about evaluating such cases is, first of all, look at creatinine-based eGFR. Do a dipstick study to look at the urine. What is the urine RE and ME based on dipstick? Do a albumin creatinine ratio ACR or a protein creatinine ratio, whether it is abnormal or not. Then do a metabolic testing of bicarb, chloride, phosphate, uric acid levels, and serum and urine glucose levels for ruling out Fanconi syndrome. Now, based on this, you can defer a biopsy if a patient is having stable eGFR over a long period of time, if the patient is having bland urine analysis, and there is no evidence of light chain proteinuria. But if the patient is come to you for the first time, then this might not be applicable. And in such situations, then go for rest of the things. Look at whether he fits into AKI stage 1 or 2 or AKI stage 3. If it is AKI stage 1 or 2, look at your GFR. And if at all, if he is an old patient, look what is the per year decline. Look at ACR. If there is hematuria, eGFR less than 60, or there is any evidence of light chain proteinuria, the patient definitely requires a kidney biopsy. In the same way, if a patient has got any feature of Fanconi syndrome, such patients again are a candidate for kidney biopsy. The problem with hypouricemia in Indian patients, this is how the Westerners look at it, is many of our patients, because of a metabolic syndrome pandemic, the average uric acid levels in our population are slightly higher. So when we say hypouricemia, we really do not have Indian cutoffs for labeling hypouricemia. So most of the nephrologists would go ahead for any patients with proteinuria, hematuria, and with a presence of a declining GFR, they would go ahead and do a kidney biopsy. So kidney biopsy, if you ask nephropathologist, they would suggest for every case, because you can pick the patients with monoclonal gammopathies much earlier. Now, based on, as far as my practice is concerned, for every patient who comes with new onset renal dysfunction, we subject them to SPP, and if they are having rapid decline, we definitely ask for a biopsy. Our nephrologists are quite good to put a needle into every patient. Based on the kidney biopsy, you can then classify your patient into which group does he belong to, and based on that, you can modify your therapy according to that. Now, for coming to MGRS, associated renal diseases, if you find a plasma cell clone, it is anti-myeloma therapy, which should be bortezomib based, or now DARA based, which should be given. Be slightly careful while giving lenalidomide. You need to modify the doses for len. And if you are wanting to give POM, that is safe enough as far as image is concerned. Thalidomide and POM are safe in patients with renal dysfunction. Now, though POM also needs to be modified, but it is not as bad as that of lenalidomide. Coming to B cells or lymphoplasmacytic clone, if the patient has, please start either anti-Waldenstrom's or anti-CLL therapy. In both Waldenstrom's as well as CLL, the either bendamustine rituximab, single agent rituximab, if the disease clone is not huge, or BTK inhibitors will be able to revert the renal dysfunction. Now, when there is an unknown clone, in such patients, either refer the patient to a reference center or a tertiary care center, or otherwise, you can still go ahead and start these patients on bortezomib if you have a IgG, IgA, or a light chain disorder, and rituximab if the patient has got an IgM protein. Or you can give rituxi first, followed by bortezomib if there is no response. So this is how we go ahead with the MGRS type of picture. So these are the broad monoclonal gammopathies of clinical significance. And just to wrap it up, we first spoke about MGUS. We spoke about how to diagnose it, how to stratify it, how to evaluate such patients, how to follow up those patients. And for those patients with MGUS who have unexplained clinical symptoms, they can have myriad of manifestations, but the top manifestations afflict neurology, kidney, skin, or the inflammatory system or the rheumatological disorders. And we have spoken about how to go about it. So with this, I would like to stop here and would like to take, if at all, if there are any questions. Thank you again, MB Agarwal sir, for giving this opportunity to me.
Thank you, Uday. That was fantastic. Questions, please? Those who are here, and if there is anything to be put up by the audience in the chat box. Satish, your question.
Thank you, sir. Thank you, Dr. Uday, for that excellent and comprehensive presentation. I have two questions. One is about monoclonal gammopathy of neurological significance. So all the conditions you presented, majority of them are IgM related. So if the neurology refers and if on immunofixation, if it is not IgM, non-IgM, can we safely say that it's unlikely to be related to the monoclonal gammopathy?
No, I would not take it that way. So what happens is, as we understand, like IgM is like Kali Mata. She has got 5 hands. So the chances of that protein leading to organ dysfunction is higher when compared to the IgG related. But we do have non-IgM related peripheral neuropathies also. So the best way to go about in such patients is to do a sural nerve biopsy if possible and send those for a good pathologist who could comment by giving an immunostaining and telling us whether there is a direct affliction or not. But again, said that there could be immunological reactions where there might not be a direct deposit of IgG or non-IgG or IgM and non-IgM, and they can also lead to these manifestations. So as long as you find a M protein component, whether IgM or non-IgM, or a small plasma cell clone, they deserve to be treated with IVIG. That's the first line of therapy in most of the disorders. Second, if the patient persists to have symptoms, some clone-directed therapy. But I would request MB Agarwal sir for further elucidating on this topic. Sir, your opinion, sir.
No, you are absolutely right. The problem that most of the people in India would face is a competent pathologist to give you an answer after you have given them the tissue. And therefore, it's very important that you know whom to send the tissue, so that, because these are not the procedure which can be done second time, whether it's nerve biopsy or it's a kidney biopsy. So it's very important to involve the hematologist who knows where to do what. Yes, you're quite right that unless you do it left and right, you're not going to pick up the diseases.
Yes, so the problem is with non-IgM only. So the issue comes with non-IgM, whether should we attribute the symptoms of polyneuropathy to the IgG or not. Right, Dr. Uday. So second question is of monoclonal gammopathy of renal significance. Sir, can I ask one more question?
Hey, one comment I have.
Sorry, sir.
Between Uday mentioned that there are in neuropathy or in neurological disorder very few treatable diseases. And we play a very important role because we have the etiology which is treatable. So I think any kind of protein abnormality with a neurological symptom, especially related to peripheral nerve, it's extremely difficult to dissociate the two till you organically document that, okay, this is not associated. How to say that this is not associated?
Right. I think, as he said, we have to do a nerve biopsy only. I mean, that becomes difficult. Nerve biopsy, kidney biopsy is at least practically very easy, sir. I mean, everyone does it. Nerve biopsies, as you said, one is doing the procedure, patient has to accept. Third is the pathologist. So 3 things come into play.
Go ahead with your second question.
So Dr. Uday, in patients with monoclonal gammopathy of renal significance, recently I was referred one case where the patient had proteinuria. The nephrologist has done a biopsy and it is reported as PGNMID, that is progressive glomerulonephritis with immunoglobulin deposits. So the proteinuria, so when I evaluated, there was no M-band, there was no light chain ratio was normal, no monoclonal gammopathy on the immunofixation. Bone marrow was normal, no clonal plasma cells. So I could not demonstrate clonality in any way in that patient, except for the kidney biopsy. There's nowhere else any clonality demonstrated in the bone marrow. When we looked at the proteinuria, it was around 956 milligrams in 24 hours. So should I treat this patient or can I wait? Because some of the guidelines say only in these cases where there is no clone detected, we can wait till it crosses 1 gram. But the patient has 956. So I suggested to them that we should treat it as a myeloma like bortezomib-based therapy. But I wanted your opinion, Dr. Uday.
So I totally agree with your line of management. So first thing, I have two comments here. So as far as treatment is concerned, these are all arbitrary numbers. So having a cutoff of 1 gram and somebody having 998, 956, it's very difficult to say what's the thing. So that is clinicians' purview about how we go about it, because we have to draw a line somewhere. So somebody has said, go ahead above 1 gram. So they are not based on exact studies to say below this cutoff, it will not make a difference, and above this cutoff, it makes a difference. But coming to your first point, so most of these patients who have got MGRS, we need to understand we would be not able to pick up a clone on bone marrow, or we would not be able to pick up a M protein on SPEP. The reasons are, as we all understand, it's a patchy disease. We are doing a marrow from iliac crest, so we are not sure where this particular clone is sitting. PET directed, with the newer PET modalities, FDG again is not sensitive enough to exactly tell us where the clone is. They are coming up with new molecules in the PET, which might help us down the line. But with the mass fix coming or the mass spec coming, the number of patients we are going to pick up saying that we did not find a clone as a hematologist would come down. So SPP, the sensitivity is very, very low when compared to the other modalities. So with the newer modalities coming in, probably we'll be able to still find a clone. And as far as management is concerned, as long as a nephropathologist, a good pathologist, has clearly proven that it's an end product of M protein, which is leading to renal dysfunction, they would require a management. So what you did, I totally agree with your line of management.
Thank you, Dr. Uday. Thank you, sir.
Thank you. Upendra?
Thanks, Dr. Uday, for that wonderful talk and enlightening us on this very rare topic and giving knowledge about those aspects. We usually we skip, we don't see those patients very often, and so usually these are really misdiagnoses. So I really had recently one patient, around a 60-year female, who had came to us with renal failure. Creatinine was around 7, non-oliguric renal failure, and M band shows 0.5 gram per deciliter of M protein. And we did a bone marrow aspiration biopsy, plasma cells not increased. So how will you proceed with this patient?
Sorry, I missed your statements in between. The patient had M protein of 0.5, bone marrow not showing any plasma cell clone. And what was the initial part you said?
Creatinine was around 7, and she's non-oliguric.
So I would go ahead and do a creatinine. If it is 7, I would definitely go ahead and do a kidney biopsy for that patient. So, but before that, as a clinician, not as a hematologist, the first thing I would do is to look at ultrasound KUB to look at the sizes of the kidney. Is the kidney size constricted or not? Rarely will you find a plasma cell disorder which will have contracted kidneys. So normal kidneys, noted. Enlarged kidneys, noted. But if you are having a contracted kidney and a patient is a known hypertensive and others, then not that it cannot be still a plasma cell disorder, but just that because the chance of bleed after a kidney biopsy will be very high, I would not subject a patient to a kidney biopsy. In this given patient, I do a urine analysis for looking for the urine composition. Is the patient having anything or not? I'll do a urine protein and a urine FLC, and I would do a kidney biopsy. So that's how I would go ahead with this patient of yours.
So if kidney biopsy is showing clonality, then we should treat this patient with MGRS.
Yes. Depending upon what it is showing, and because you also didn't tell us how much is the proteinuria and others, so it all depends upon what part of kidney is involved. So according to that, we can take up the patient further. And also no hypertension, no diabetes, which are more common causes for such high creatinine or non-oliguric in our country.
Thank you.
Thanks, Dr. Upendra. One question from the audience. A question from Dr. Gopinathan. 35-year female, epistaxis, skin rashes, M band 3 grams, IgG lambda, FLC ratio normal, What is 10%? CPC, 10%, no crab, serum viscosity 2.1, mildly impaired platelet aggregation function. What do you label this patient and how do you manage?
So Dr. Gopinath, a nice summary, but if a patient is having circulating plasma cells of 10%, so as such, the patient would go into a diagnosis of myeloma. So here we are not discussing of MGUS anymore. So with such high circulating plasma cells and with a patient having 3 grams of M protein, so we definitely need to think in lines of thing. And with patient having increased viscosity, patient having platelet aggregations. So there is some amount of factor that this M protein is also leading to some amount of hyperviscosity. Now, sir, sir, I missed whether it is IgM or IgG. What did they say?
Not mentioned.
Okay, so please look at IgM because these manifestations would go more hand in hand with IgM. But otherwise, even if it is non-IgM, so the patient would immediately need to be subjected to therapy. And but before giving rituximab or any plasma cell directed therapy, be careful to see that the patient how much is what type of protein are we looking at, because circulating plasma cell 10% is quite high actually.
I think his worry is that 1 FLC ratio is normal and 2 crab is not fulfilled.
Okay, so that's a good question. So point is, please again understand, whenever these criteria, these diagnostic criteria and various other parameters or cutoffs are made in the world, so across the world, people will say, this is seen, this is seen, this is seen. They will say, what are common? Then thereafter, the committee says, what is feasible? Then they say, what is the applicability at the bedside? So previously, hyperviscosity was a part of the myeloma defining events. The neurological manifestations around 15 years, 20 years back were part of myeloma defining events. Weight loss used to be a part of myeloma defining events. So absence of CRAB does not mean that the patient does not have a myeloma defining event. So if you ask experts like MB Agarwal sir, who has been practicing for decades together, they would have seen so many patients of myeloma without exactly CRAB with other clinical manifestations. So as long as you are convinced that this particular M protein and this particular clone is leading to this particular manifestation, that is sufficient enough to call that the patient has got an overt myeloma.
Yeah, and you had asked about IgM, IgG. He has mentioned it is IgG in this patient.
Sir.
And one thing I was just wondering, when patients presented with bleeding, then will you do factor 10 and look for amyloid?
Yes, sir. Yes, sir. So yes, in fact, I missed saying that we should rule out amyloidosis in these patients.
Right. Second question from Dr. Shyam. 74-year female, diabetic, proteinuria 2 grams, mild increase in lambda chain in urine, bone marrow and blood, no active disease. Kidney biopsy not feasible. How do you rule out MGRS?
This is a fishy situation. But first of all, when you said that the urine is showing lambda, so there is no reason why a urine should have lambda light chains. So in a normal individuals, they will never have. Second, when you said proteinuria of X percentage, we again need to classify. Protein is a big thing that you're talking about. We need to say how much of this is albumin and how much of this is non-albumin protein. And we need to classify that further to say that this non-albumin protein has what all compositions. And if it has got a high composition of, as you said, lambda, so if we can exactly quantify that, again, that will give us an idea to that. Now, non-feasible renal biopsy, we really cannot say much about MGRS because on today's date, MGRS diagnosis hovers around a kidney biopsy. But maybe this patient, you can subject them to the rest of the myeloma evaluation as bone marrow biopsy and serum M protein and other factors, SIFE and mass spec to see if you get any surrogate features of having a plasma cell clone present anywhere. But if you want to label the patient as MGRS, kidney biopsy is more or less required.
Right. Dr. S.K. Sharma, what protects kidneys from plasma cell infiltration? Why do the deposits do not occur? In MGRS with glomerular nephritis, what is the mechanism? Is it always immune mediated?
So there are two parts to the question. The first part, I really don't know that what protects them from the plasma cell not getting infiltrated, but we rarely find it. It's an observation. So the exact pathophysiology, I'm not aware of. I will confess on that. Now, coming to the second part, when we say glomerulonephritis, so as we all have read from our pathology days from Robbins, the glomerulonephritis is a huge bundle or a basket of disorders in itself. You have got mesangial-proliferative, you have got infiltrative, you have got focal sclerosing glomerulonephritis. So you have got different varieties of it. So yes, many of them are immune mediated. Some of them could be because of just the protein getting deposited. Some of them can be a sclerosing reaction to that focal sclerosing. So different types. But as far as the M protein related are concerned, most of them are the immune deposits which lead to it.
Right. Now, just one remark about this. Kidneys do not have plasma cell deposition. In our days, we used to say spleen, which is a very vascular organ, almost never has secondary deposits in the spleen. Whatever may be the primary anywhere, to get the secondaries in the spleen is very rare. So environment of the tissue is important, and that probably in kidney is against the plasma cell deposition. That's all. What Shilpa, your question?
Good afternoon, sir. Good afternoon, Dr. Uday. Very nice talk. So I just wanted to know, like, if there is an entity called MGRS. Now, do we have a defined entity called MGNS? And if yes, what comes under it? Or the entities that you described, do they all can be classified under MGNS, monoclonal gammopathy of neural significance, or what we label it as, it will be labeling it as neuropathy associated with MGUS. So I just wanted the terminology.
So as far as the IMWG is concerned, they will all be labeled as MGCS bracket the particular organ which is involved. So it will be MGCS bracket neurology, MGCS bracket so and so. So we have some labeled syndromes. Anything which is sitting other than the labeled syndrome, you can just say monoclonal gammopathy of clinical significance bracket neurology. Now again, terminologies is something which are somebody's ideas where they come up with new names, new things. So I feel the nomenclature might not really matter as long as the way we are managing these patients, we have some homogeneity on managing these patients and trying to make sure that the symptom reversal take place. So, but yes, I have seen few articles where people have labeled as MGNS and others, but I'm not really sure whether that is approved by the IMWG or any group which works on myelomas. I need to work on that. I'll come back to you on that, Dr. Shilpa.
Thank you, Dr. Uday. One more just small question. There is, suppose a patient has a single lytic lesion detected incidentally on a PET scan while working up for the same, any monoclonal gammopathy of clinical significance, which is asymptomatic. Patient is not symptomatic for that particular lytic lesion. And the monoclonal gammopathy is maybe, say, less than 0.5 gram%. So what will you label this as? Will it be labeled as solitary plasmacytoma causing the clinical scenarios of plasma cell dyscrasia, or monoclonal gammopathy of clinical significance with a single lytic lesion? And how do we handle that asymptomatic lytic lesion?
Here there is some amount of, I would say, answer for that, which I could say. So this is solitary plasmacytoma. But now in the new classification of MGUS, solitary plasmacytomas have been included into MGUS itself. So as long as they are not having any symptoms, so less than 2 bone lesions and the patient is having, that means basically 1 lesion. So 1 bone lesion with just M protein, and on bone marrow, the patient does not have any clone more than 10%. So they would be labeled as either solitary plasmacytoma or MGUS bracket plasmacytoma. And as far as therapy is concerned, so if it is single lytic lesion without any symptoms associated with it, they can just be observed and followed up. Or otherwise, if you have to manage, if you feel that it is leading to some amount of symptoms or the PET avidity is very high, so in such patients, they can be subjected to radiotherapy for that local area. 50 grays is the dose which is suggested for solitary plasmacytomas.
Okay. One more question. Sorry, if I can ask. Can I ask, sir?
course.
The neuropathies which are associated with the monoclonal gammopathy of unknown significance, are they mainly axonal, or are they mixed, or are they demyelinating? And is there any difference in the treatment outcomes depending upon the difference in the type of neuropathy?
This is a very, very good question. So first, they could be mixed. You could find both demyelinating as well as axonal. The pathophysiology is different. In demyelinating, it's the cells on the top of the Schwann cells which get affected, whereas in axonal, it is the Ranvier nodes which get affected. Now, as far as the outcomes are concerned, the axonals take a longer duration for a recovery when compared to demyelinating. Demyelinating recover faster. Now, coming to those which affect long fibers versus short fiber neuropathies, the short fibers recover faster when compared to long fiber neuropathies. And as far as the type of therapy is concerned, I am not sure. IVIG still remains to be the type of therapy, but both demyelinating and axonal neuropathy, but just that the recovery time would be faster with the demyelinating.
Thank you so much. Thanks a lot. Thank you, sir.
Thank you. There aren't more questions. Uday, I have 2 questions for you.
Sir, you're not allowed to ask questions. You are supposed to only give comments or suggestions. In fact, most of the times when we sit across you, it's like we giving a grand viva. So you have taught us, and something saying in front of you is really very risky. Or we are really, I would say it's a moment of pride, but at the same time we are scared that hope we don't make any mistakes, because there's nothing parallel to your experience, sir.
No, you can take it as comment rather than question. But before that, there's a question come up, so you take that first. Nikhil has a, sorry, not Nikhil. Dr. Gopinathan has a question. 62-year-old male, diabetic, right leg shooting pain, NCS no demyelination, M-band 1.03, IgG kappa, and the kappa is 462, lambda is 8.2, ratio is 56. Bone marrow aspiration and biopsy are hypocellular. There is no increase in plasma cells. PET scan shows sclerotic bones, both iliac bones. Electrophoresis of the sclerotic lesion, the histopathology shows clonal plasma cells and additional investigation. Okay, what are the additional investigations needed and how will you manage this patient? So you got sclerotic bone, there are clonal plasma cells, there is a M-band of 1 gram, it's IgG kappa, SFLC ratio is 56.4. Bone marrow in general has not shown any increase in the plasma cells, and the man is diabetic with a shooting pain in the right leg.
Dr. Gopinath, whenever we come across a patient with shooting pain, so the first thing is neurologically we are looking at a radiculopathy. So when we are looking at a radiculopathy, the most important investigation which needs to be done is an MRI of the spine. In fact, in the neurological features, when we talk about difference between doing a PET versus an MRI as a baseline investigation for these patients of myeloma, so this category of patient which we have shown is the ideal patient to undergo MRI and to look for MRI spine. Now, once we see that it's not a plasmacytoma which is sitting there, both intra, oblique, extra, medullary. Here, medullary is not bone, the spine, that's what we are talking of, which is compressing onto the radicals. Then comes the question that is it secondary to the M protein or is it secondary to the diabetes? Because even diabetes can lead to these sort of pains in bilateral regions. But first thing first, MRI, as far as your question is concerned. Now, second thing, as you said that the biopsy of the bone shows still clonal plasma cells. If it is more than 10%, then it is straight away myeloma. And irrespective of whether this shooting pain is secondary to the myelomatous process or not, the patient would definitely require, because the patient has M protein, has got an abnormal FLC ratio, and the patient has got bone marrow plasma cells more than 10%, he would fit in for getting a treatment anti-clone directed therapy, which needs to be taken care of. Now, as far as shooting pain is concerned, after the MRI spine, if you don't find anything, then NCS and EMG are the second things which would help you in labeling what this patient is having and why this shooting pain is taking place.
Right. Yeah, so that finishes the questions. And now my remark, okay? So one is regarding the diagnosis of MGUS versus the clinically significant monoclonal gammopathy. Now, with all the recent workup, and as you mentioned, beyond certain age, every alternate person you can document plasma abnormality. Now, each manifestation that a monoclonal gammopathy does can have an etiology which is not connected with monoclonal gammopathy. Now, unless you document that there is a relationship between the two by biopsy, how do you really say in an individual patient that this is related and this is not related? Has been always my question. And the moment I say that, okay, we have not been able to document that the lesion has to do anything with kappa lambda, then the question comes, is it immune mediated? And still it is related to the plasma cell abnormality. And if you say, yes, that can be, that means every patient needs treatment. The moment you document there is a protein abnormality and there is something, and that something has become now so wide, probably anything in the body is not left today. That's my one dilemma in my mind from last 4 or 5 years. Once when I heard Angela, you mentioned that 2020, when she presented that paper and it came in the ASH education book. The second question is that we keep talking about that there should be criteria for treating plasma cell dyscrasia. Now, this is what we did at the student. And probably the reason was that we didn't have very effective treatment. The mortality and morbidity of the disease was still very high with whatever melphalan, prednisolone we had. Now with better and better and better treatment available, and we moving from CRAB, etc., to high-risk smoldering myeloma to probably low-risk smoldering myeloma to now talking about monoclonal gammopathy of clinical significance, we are moving to lesser and lesser disease and trying to attack the plasma cell. So does it come to that the moment you say anything is related to a plasma cell clone, it needs treatment? You want to give your comments? You're welcome.
Sir, Nick, sir, what you brought out, both the aspects are more philosophical queries, because I agree with you, sir, with the way we are progressing in medicine in trying to pick pre-malignant, pre-malignant conditions, trying to pick the disorders at a very, very early stage. Definitely this dilemma occurs, should we first manage them or not? Second, as you rightly brought out, because M protein by themselves or the plasma clone by themselves might not lead to symptoms, even an immunological reaction to that or various immunological manifestations can lead to various symptoms. So what to manage, what not to manage. So if it comes as a bedside query to me, sir, if a patient stands in front of me with this problem, the way I would look at it is, I would take this MGCS as a diagnosis of exclusion for certain disorders, where I've got better explanations for other problems for that particular given problem. So if I have got a treatable, better explanation, I'd go with that. But if I have got no other treatable conditions for whatever component of that particular symptom, which is reversible, and if when targeted, so the risk benefit ratio of treating that individual weighs over the disadvantage of the complications or the cost involved or not doing anything. So then I would go ahead and manage it. And I very strongly feel a good physician versus a bad physician, a natural intelligence versus artificial intelligence, this is a place where it actually works in, wherein a person with more maturity and more experience would take a more balanced decision in such situations rather than just going by guidelines and by the books or by listening to a lecture and just saying from tomorrow onwards, every neuropathy, I will start managing them with IVIG. So it is a balance which every physician has to do, considering various confounding factors. More importantly, in our situation, finances as well, and the amount of mental trauma it will put across to. Like, sir, when I'm going to present this in the MHG annual meeting about this MGUS door-to-door survey, around 62 patients among 1 lakh, I've told them that you have a cancer now. the mental trauma these patients are undergoing, and they keep calling me for every symptom of theirs. आज बुखार हुआ सर, ये कहीं कैंसर का तो फीचर नहीं है. Should we start evaluating or screening individuals for all these disorders so early? Is it really helping the community or not? So these are the dilemmas which are there. So putting together, we as a society need to draw a line somewhere saying that, okay, for our society, in our situation, for this group of people, this is where we would start treating and we will not start treating, rather than just adopting whatever the Westerners are writing and sending it to us. So I really do not have a scientific answer for your query, sir. So this is something which we should all mull over or sleep over to understand where we should start treating and where we should not.
6 months ago, Newburgh did a sponsored meeting. Attendance was 250, 300 in ITC in Mumbai. And one of the presentation was concluded the serum protein electrophoresis immunofixation free light chain assay should be done for all the people above the age of 40, irrespective of what the patient has been sent to the pathologist for whatever test. And now, this was one extreme. I vehemently opposed it. Exactly what you're just now putting it up, that where will this lead you to? It's just like doing genomic studies in the relatives of patients of cancer.
Yeah.
Whatever happened to the breast cancer program a couple of years ago. So it's the same thing where the plasma cell dyscrasia are going into. If you start screening like that, and tomorrow once they have the access to mass, they'll start doing mass for everybody. It raises questions where a clinically insignificant finding, how to dissociate it with what patient has got and whom to treat, whom not to treat. Giving IV gamma globulin may still be okay, but giving a clone-directed treatment will be a big question, which comes up as and when the IV gamma globulin fails. Sometimes what I've done in practice, which may be right, may be wrong, is to give a 4-month trial of clone-directed therapy. If nothing happened to the clinical event, tell the clinician that, okay, probably the two are not connected. But that is an approach which is, again, you can call it philosophical, or you can call it very, very empirical. No documentation, there can never be a proof to this. Right, I think this is beyond 1 o'clock. We call it a day unless somebody wants to say anything more to Colonel Uday. Okay, Uday, thank you so much.
Thank you, sir. Thanks again for this opportunity.
It was very wise with your wonderful presentation. It was really very, very useful. And I'm sure all the listening guys from all over, not only India, from all over, must have tremendously benefit. At least you generated an interest in them to read more and more about this subject. And this subject is something which is very, very new and is opening up in various ways. So yes, it was important to discuss this. Thank you so much. Have a wonderful day again ahead. Bye-bye.
Good day, sir.